Okay, here we go. We're gonna have these monthly meetings. So what are these monthly meetings for? One, if you attend the monthly meeting, even if it's just you, who is the leadership right now that I'm aware of, you will be able to submit, and only you. So chapters who missed the meeting, even if we post this on YouTube, this month is an exclusion because it's such a new thing we're doing. But starting in like February or March, chapters that don't come will not be able to submit. That being said, I know the whole submission process is kind of a headache for a lot of you guys, maybe even a responsibility or a chore. But I want to emphasize that it shouldn't be, and that it's actually a reward, and that it is posted somewhere where admissions councils can see and credit you towards. So writing's really important. Those who come to these meetings will be important. But the second goal of these meetings is that we want to create a community and foster a relationship among you all. And I know that's like, Sam, what are you talking about? You're just yapping the entire time. How will that create community? Trust me, I don't know. But we're gonna figure it out together. And I'm hoping that even just the three of you guys sitting on a call together with us will generate a sort of closeness and intimacy. I mean, more than you realize, it's pretty epic. I mean, there's three different schools represented here, if I'm not wrong. So it's really exciting to see you all. So uh, here is the quote that I wanted to start with. Does anyone want to read it?
Yeah, I can read it. All of the sons of Adam are part of one single body. They are of the same essence. When time affiliates us with pain in one part of that body, all the other parts feel it too. If you fail to feel the pain of others, you do not deserve the name of man.
Wasn't that so cool? So, who's Carlo Rovelli? He's a physicist. He wrote this book called The Order of Time. And I love this quote. He's a poet, he's a great writer. He brings information in a really generalizable way. If you ever read his novel, you'll understand why I brought him up. He's doing something similar to what we're doing. We're taking science, we're making it meaningful for lay people or for even for each other, but to make it more accessible. And so it's a really great example of what we're doing. Second, I love this quote because it's the essence of dream and what the essence of your future practice should be. You know, at the end of the day, everyone wants to be a doctor because they want to be like the cool guy with scrubs on who's always busy, like, oh, look at what I'm texting about lactate or whatever. But the important thing isn't that. The reason why we're physicians at all and the reason why we wake up is because we are a common body of people. And when one of us feels pain, it's a natural tendency to want to help. It's an empathetic and compassionate and sophisticated component of the human ethic center. And so I think this is really important because once again, at Dream Journal, we're not trying to just emphasize the evidence or the literature or understanding a scientific article or getting you research so you can get into medical school or dental school or whatever. The main point is that the durable response is that you and the teams of people you'll be leading come out of our experience and say, I know how to make research compassionate. You know, in the book, Carlo Rovelli suggests that science is rebellion against the natural world, meaning that science is the endeavor to rebel against what's put in place for us. But I would say compassion then is a rebellion against the unnatural world. Corruption, greed, evil, it can only be combated by people like you. And so this is a really important quote. And this is the center of Dream and the center of what it means to be an evidence-based clinician. The biggest difference for you guys, since you've already been and doing this for a long time, is that our writing style is going to change, of course. We're going to produce more YouTube content, okay? That's like virtual shattering opportunities for different specialties. Why? Because we know a part of you guys in this whole journey as a medical, like pre-medical student, is wondering where exactly you'll end up. You know you have to go to medical school, but you don't know what comes after. So we recognize that we'll produce some content for you. Third, you guys know that chapters are really active. So we wanted to minimize the time you're spending on planning. And so just inviting your membership to come to these meetings is probably the most and easiest way to kind of engage your people in your campus. But yeah, having general body meetings is sort of the next thing. We're also going to start providing asynchronous material that's going to be based largely on Dr. Guyette. He's like the father of evidence-based medicine's user's guide to the medical literature, currently hosted by JAMA. And then we're also going to have a podcast we're going to start in 2 weeks called Bedside Stories, where we sort of just break down the evidence with sort of experts. I think this month we'll have Dr. Kagi. He works at Newport Beach. He's the medical director there at HOAG Medical Center, and he's an absolute phenomenon. And he's started multiple companies, just a genius mind. So now you're asking how you can fit in. The big things I want to highlight for the people who will watch this through YouTube, and then you all who are, been with us for a long time is what can you do to fit in and be a part of a culture? One, of course, is wait, how do I? Oh, start a chapter, run a chapter, rally people. That's what you're good at. That's why you're a leader. That's why you're here. Second, what you can do is consume the content we create. And I'm not just saying that because we want views. But the reason why I say this is because we really endeavor to provide a service for you all. to provide something that maximizes your time, that engages you, to provide the experience you need to really accelerate your career, but most importantly, become a really good doctor at the end of everything. And so we're not doing this just because we can. I'm doing this because I really think it's important, and I hope you guys recognize that. So consumer content, create a chapter, rally people, do whatever you want, and we'll back you up and provide help in any way. So there's that. Third, we're gonna hold two competitions, and this is when you guys should really pay attention because I know someone's falling asleep. Um, the two competitions are this. One will have $150 in scholarship money to the best chapter. What does it mean to be the best chapter? We haven't fully fleshed out what the selection will be, but what we know is like coming to meetings like this, engaging with us in a pretty serious way, that that will likely and most likely earn credit towards you so that by September you'll be able to earn $150 for your chapter. $150 is not a lot compared to maybe what some schools can offer, but it's definitely something. And maybe it's just something that you and your, three or four members can go and get a really nice dinner with or something. So it's something we want to provide. Second, there'll be a $250 scholarship for an individual based competition where we're going to start designing a writing competition. Likely will be is a modified case report that we'll publish on our website. That's about an empathetic case report. So how was there a case in which a physician really provided empathy with the literature to a patient who really needed it? So we're gonna have a conference in September, without a doubt. The dates haven't been fully fleshed out. We'll have a conference in September. So the more people you can rally, the more people you can come to that September conference, the more fun we'll have. The September conference will mostly be about a whole bunch of people kind of teaching about the different medical specialties, and then we'll have an abstract competition too. And if you're interested in submitting an abstract for that abstract competition, we will release information about that in February, March. So there's a lot of ways you can plug in and a lot of ways you can benefit from us. This is mostly for the people who don't know me well. And so just get in contact with us. Ask us silly questions. Waste an hour of our life or yours just doing whatever and asking questions and figuring things out because we want you to be as dynamic as possible with us. Because that's the end of the informational part. So our month topic this month is breakthroughs in oncology. You'll have 2 weeks to write. So you'll have until the 27th to finish writing. You're yourself and the people you'll rally. I know that expedites things, but I wanted to give you that kind of stringent timeline and make it really, tight because I just expect that most of the time giving more time is actually deleterious in these types of situations. If you have friends who you think will benefit from this, just tell them to write really quickly. It takes like an hour and just write. These are our objectives, a lot of objectives. Mostly, main important thing is probably objective two, to think critically about compassionate care. So this is a game we're going to play. This is a brief overview of therapeutic modalities for cancer. This is for your good knowledge. This is so you can flex on the attending you'll eventually shadow. Kevna, I don't know why. This is for you, mostly just trivia, maybe, or maybe it'll come up. What do you think in 1500 BC was the first type of therapy for tumors?
You said the tumors, right? The defenses against tumors.
Mhm.
I don't know, probably like some sort of like excision. You just take it out. Um,
Bingo. Yep.
yeah.
So in 1500, the Egyptians were the first to write on, maybe they did it before, but on papyrus, they wrote about how they excised tumors. Let's skip a little bit. So a lot of that was like a lot of 400 BC, 200 AC was just development of cancer theology. 1898 AC, what do you think happened? Arion.
Did they start doing more like therapy based, more radiation based, or?
Yeah, yeah, 18, yeah, 1898. Marie Curie, Mary Curie, how do you say her name? Whatever. She was the first to try radioisotopes against, and that's the birth of radiotherapy. Let's skip to, okay, so 1940s, they started using chemotherapeutic agents, specifically like nitrogen mustards and alkylating agents. Kevna, what happened in the 1940s that they started using nitrogen mustards, you think, for cancer?
Honestly, I have no idea. Maybe the cancers got like bigger, metastasized.
Yeah, I should have asked that question in a better way. World War II happened.
Got you. Okay.
Yeah, World War II happened, so they started using biologic warfare, and they figured, maybe what's been killing these people can actually be used to kill really bad tumors. And so they started experimenting with that. 1980s, I'll save you guys time, was monoclonal antibodies. 1992, trastuzumab was first, I think, trialed, I believe. Does anyone know what trastuzumab is for? It's for breast cancer, specifically a type of breast cancer. Okay, it's HER2. It's a monoclonal antibody against HER2. 210 onward, we started playing with immune checkpoint inhibitors, which I'll talk more about. So what are immune checkpoint inhibitors? Essentially what's going on in your immune system, and your immune system naturally wants to prevent autoimmunity. What do I mean by that? Cytotoxic T cells, CD4 positive T cells have some interaction with something called MHC class 2 and 1. If you guys know what that is, antigen presenting cells have those. Most body cells also have MHC class molecules to present. But dysregulation of those can cause autoimmunity. Why? Because cytotoxic T cells can attack your body's own cells. So in order to prevent that, we have immune checkpoints, such as program death ligand 1 and program death 1 receptor. And so when those are upregulated, the body naturally knows not to attack those cells to prevent autoimmunity. This is especially useful in understanding things like multiple sclerosis or other forms of cytotoxic mediated autoimmunity. That being said, people started figuring out that some of the worst cancers that are, fantastic, like almost like fantasy-like that we've talked about over the past 3 decades, like melanoma, are actually upregulating those like PD-1 receptors in an effort to avoid the immune system and grow and become more insidious. And so there was this huge movement, and it won a Nobel once they discovered these two receptors, specifically PD-1 and PD-L1. There's this huge movement to actually inhibit those. And what happens when you inhibit those is that cytotoxic T cells were actually able to do their job and kill and attack cancer cells that originally were hiding by upregulating those molecules. There's antigen presenting cells, MHC class 2, which interacts with CD4, and MHC class 1 that interacts with CD8. So please remember that. In all this discussion, there's a wonderful physician named Dr. Michael Lim. He's like literally my favorite person on earth. If you ever meet him real life, you'll understand why. He's the kindest man I've ever met. He was a neurosurgeon originally at Hopkins who moved to Stanford. He's the chair of the neurosurgery department there now. And he trialed nivolumab, which is a PD-1 and like PD-1 upregulator, I believe, or no, PD-1 inhibitor. That's what I meant. Sorry, it's always like up, down, left, right, positive, negatives, in an effort to treat glioblastoma. Glioblastoma is one of the hardest cancers to treat. It's probably one of the deadliest. With poor 2-year prognosis. Most of the time with cancer, we talk like 5-year prognosis. Poor 2-year prognosis. It's an absolutely detrimental disease. It occurs like little later in life. It's rare, but it's still the most common primary aggressive tumor of the brain. So adult tumor of the brain. And so he saw his colleagues using PD-1 inhibitors for things like melanoma and non-small cell lung cancer, and he just saw those cancers melt away. So he tried it with glioblastoma. It worked really well in preclinical models like mice, and so they ran this clinical trial. This clinical trial did not show any difference between using the PD-1 inhibitor and using placebo. But I like to point out one thing before we get into this MCAT style question is that a lot of people will look at that and be like, oh, he like failed science. But the second kind of quote I want you guys to remember, in addition to the rebellion quote, is that science is driven by the most humble people. And so it's not about being right. It's not about getting positive results. It's all about proving a point so we can drive therapies in the right direction. I think we should always all remember that. But here's an MCAT style question. I think this is how MCAT's laid out. You can read it, and then I'll go through these graphs, and then we can answer a few MCAT questions that I made. So glioblastoma is an aggressive adult primary brain tumor. Standard of care currently is surgical resection. Specifically, I think super resection is agreed upon these days with adjuvant radiotherapy and temozolomide. Let's remind ourselves that temozolomide is an alkylating agent. Recent advances in immunotherapy demonstrate that inhibition of upregulated program death 1 receptor has shown to improve cytotoxicity against tumor cells. Investigators recruited patients with methylated O6 methylguanine DNA methyltransferase promoter status. Let's remind ourselves that MGMT status methylated MGMT status is concurrent with better prognosis, usually, in a site subject blinded randomized controlled trial with 2 therapeutic arms. So let's also remind ourselves that site subject blinded means that one person does know what the patient got, but neither the patient nor the institutional PIs know. Okay, so it's nivolumab with standard of therapy or placebo with standard of therapy. And here we have the 2 charts. What basically this shows that A and B demonstrate that this regardless of PD-1 expression, Progression-free survival. So let's remind ourselves that progression-free survival is the point in which treatment happened and the point in which therapy, like the disease got worse, was like basically insignificant between the two arms. And then let's look at C and D graphs, which show on Kaplan-Meier's, once again, the overall survival also there is no difference. And in fact, I think in D we see that placebo actually did better, which is slightly alarming when it comes to looking at the efficacy. But still, it was, no difference between survival between the two. Okay, so this is based on objective 3B structure and integrative functions of main organ systems tested by the MCAT. Okay, so researchers find that cytotoxic effects of T cells are regulated. Essentially, what does it mean when it means that T cells have increased activity against tumor cells? So you would probably get to think the point where you think it's either A or C. Why? You're thinking it's upregulating the immune system's natural affections to destroy bad things, which is a good idea. The thing is that a cytotoxic CD8 cells specifically are reluctant to do phagocytosis. You know which cells do phagocytosis pretty often? So CD8 positive T cells actually are cytotoxic for a lot of reasons, but one of the main things is that they'll release these death-inducing substances. And that's sort of like buzzy for maybe things like cytokines or even things like granzymes, perforins. One more MCAT question. So now you guys are kind of pumped up like, oh, maybe this is harder than I thought. Methylated MGMT promoter status is associated with better prognosis. This is a genetics question. If you've taken genetics, what is true about the effects of methylation on the promoter? What would that do to just in general DNA transcription? I mean, this is, yeah. Reacher?
I'm gonna go C. I think
Guys,
something has to do with like the repressor or something like that. Like because they're always paired, right? Promoters always or something. I don't know. Maybe my memory is a little hazy, but out of the other options, I think C is probably my best bet.
C is absolutely right. Four ideas I think you're hinting towards. Usually things that are methylated are inactive portions of the DNA.
And then acetylated if that's the correct way to say it, is the more active version, right?
Yes. And
Yeah.
actually, just for everyone's review, what is acetylated usually that activates DNA transcription?
Like the histones get acetylated, right?
Yes.
Yeah.
Yes. Yeah, that's right. Good
Cool.
job. Okay, so now is a challenge prompt, and this is kind of going to what like you'll be writing about. What is a challenge prompt? And what we want you to write is that, okay, so you know all this scientific information, histones acetylation means it's increased transcription and stuff. But what if a patient comes to you and says, hey man, I have like this horrible GBM, I'm really old, and I want to try nivolumab. So what did we just say? Nivolumab wasn't shown to be better than placebo. What if someone asked for it? Right? What's the compassionate thing to do in that moment? And so I was going to go through all these guidelines with you because eventually you will to write, and so will your peers. And I wanted to teach you a little bit how to use it. I have put these guidelines on the Google Drive you'll be using here at the end that will explain. But essentially, you would look at these guidelines and say, okay, so he's over 77. So we click on that little link there, and this is what comes up. So he's over 77. He has a really poor performance score. That's what KPS stands for. So really what he's due for is, in addition to surgical resection, maybe something just like hypofractionated radiotherapy alone, or TMZ, or even palliative care. He's 77, really poor performance score, but he wants to try nivolumab. So this is what the guidelines say. And now we know a little bit why the guidelines say that. There's a lot of literature out there. I would really endeavor for you guys to read that literature a little bit. But essentially the question, that giant thing, but essentially I was trying to ask you is like, what would you do? So Ariane, what would you tell a patient? He has horrible glioblastoma. The guidelines say he really is only due for things like TMZ, hypofractionated RT, but he wants nivolumab. But we know nivolumab might not work as well as just standard of care. What would you tell him?
I mean, I would try to be as like compassionate and empathetic as possible towards him because, like, obviously he's in a tough position, so I wouldn't try to act like I try to be as like try to be like I'm in this position as well and try to be empathetic.
Yeah, absolutely. Arisha, how about you? What do you think? Like, in addition to all that.
I think kind of going back to the evidence-based portion of everything, I feel like if I were to put myself in in that position, obviously I'd be going through it, but I would also want to know why I'm going through it and why the doctor may advise against going one direction versus the other, right? And I think that appeals to not only the logical side of things, but I feel like there is a correlation between being an empathetic doctor while also providing details to the patient, because I feel like they are, more than deserving to know that type of information as well, right? Obviously, you can't do that with every patient. You can't get into the nitty-gritty with every patient because honestly, sometimes that's not what they want to hear. But I think it really just really comes down to the situation, how you kind of feel out the interactions that you're having with your patient and see, hey, does he or she really want the details, or do they kind of want more of a comforting shoulder? So I guess it really depends on the situation, but that's probably how I'd go about it.
I think you guys both hit it exactly where it's meant to be. That you need to provide with compassion, like Ariane says, just meeting them where they're at, putting them yourself in their shoes, but also like Areesh was saying, but also explain to them what's going on. And because they deserve to know the fullest of opinions before they make a decision for themselves. And so that's sort of just the way like you guys answered is sort of the direction we want to go in Dream now. Sort of reiterating, growing, and creatively developing that exact strategy because it's probably the most tactical and realistic and practical skill for you guys as you move forward into practice. And so we have this in the Google Drive that I'll send to you guys now, where you'll submit your writing with your chapters. And just like we had this time together, you'll relay the same information and exercise with your peers or your team that you're rallying to use this template to do exactly what we did today. Find a guideline that I put inside the drive there for glioblastoma, pancreatic adenocarcinoma, or diffuse large B cell to find a guideline and create a challenge prompt. Like, what if this happens that challenges the guidelines or makes the guidelines a little bit more sophisticated than it has to be in an appraisal? Like you guys just did. What does it mean to explain to them what Nivolumab did, what the study found? What does it mean to provide compassion in that moment, to be empathetic in that moment? So this is a new thing instead of just the boring all like reading one single article and summarizing it, because it actually takes creative power from you. And also, I think we can also generate a level of mastery from you and your team. Because I promise you, whatever medical school you go to, it won't have this. And so you need to be the beacon of hope in that medical institution and say, like, hey, attending, hey, my friends in medical school, like, let's bring compassion into evidence-based medicine. And so I think this is it. Yes. I'm gonna share this with you guys now in the chat. And this is where you guys will be submitting to. It's also on the website. So like don't tweak. And just share it with your peers and rally people like you guys always do. And that's it for this month.